Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent sponsorship from Johnson & Johnson.
Hi, everybody. A very warm welcome to all of you to this educational activity entitled Patient-Centered Care in Newly Diagnosed Multiple Myeloma, Navigating Triplet and Quadruplet Therapy. I'm Mohamed Moti from the Saint-Antoine Hospital and Sorbonne University in Paris, in France. And it's my great honor to moderate this activity brought to you by Medscape Global Oncology. I'll be joined today by Dr. Paula Rodriguez Otero from the University of Navarra, Pamplona in Spain. We will have also the pleasure to listen to Mr. Vincent Klaus, who is a myeloma patient. And as you all know, we've seen quite some amazing and incredible advances in the field of multiple myeloma recently. And if we are running the Olympics of myeloma, I would say gold medals will be all over the place. However, these advances should not hide the fact that we have to take into account the patient perspective in the decision-making process. And this is why in this program, very unique program, we will explore the patient perspective when it comes to treating newly diagnosed multiple myeloma. We will also confront this to the physician perspective, and then we will figure out how to navigate all of this both from a patient perspective, but also from a medical perspective, and how to incorporate all of these advances in order to improve patient outcome. So without any further ado, I would like first to invite Mr. Vincent Klaus to give us, through his eyes as a patient, the patient perspective when it comes to newly diagnosed myeloma. So Vincent, the floor is yours.
Thank you, Professor Moti, for having me in this program, and good afternoon, everyone. I would like to give you in a couple of minutes what's going through a new patient's mind when it's getting diagnosed. And first of all, if we're talking about blood cancer for a patient, we only have one word in mind, is leukemia. We don't know everything about possible other blood cancer. And if we're talking about multiple myeloma or KALR, this is something we never heard before. Everything in multiple myeloma is complex. Even a name, if you want to talk about multiple myeloma, the name is even really hard to maintain. So the awareness and the knowledge about the disease is quite important at the very beginning. Again, very complex, and complex as well in terms of different possible therapies and treatment options. The most important element, what we see from a patient perspective, is the quality of life. And this can be different from a patient who is younger or older. We do have different perspectives when we're getting diagnosed. If we are younger, we are thinking about a job, we are thinking about building a family, we are thinking about financial elements. If we're older, we are thinking about the next step in life, of course. One important thing as well is, if we are a younger patient, how can we ensure that we are getting that we are helping our all parents and older people that are among us. So we are with the disease, but we need to take care about the parents. So it's very complex, and it's totally unknown when we're getting diagnosed. So the information is crucial, and the awareness and the knowledge of the disease are crucial. Again, when we're talking about the disease and about the different option, is the patient eligible for stem cell transplant or not? And it's, again, very important to make the real good diagnosis in function of the patient, because we know that multiple myeloma is different from patient to patient. So the discussion and the conversation has to be open with the patient. Shall we go for doublet, triplets? It's not a decision from the therapist only. Again, if we're looking into the quality of life for the patient, which is crucial in the decision, a conversation has to be open with the patient, and to have the real perspective of getting a triplet or a quadruplet. What are the different elements? What are potential adverse events? Shall we go for a clinical trial in some cases or not? Again, it's really depending on the patients. We know that as well. As patients, we're totally different from each other. But it's really important to have that conversation and that exchange between the therapist and the patient. The factors, if we are looking into multiple myeloma, and we know that this is incurable today, at least today, we know that it's incurable. So from that perspective, knowing that we will live from the rest of life with the disease, one of the most important thing, I already said it, is the quality of life. So I think that one of the most important elements when we're choosing, or when the therapists are guiding us towards a therapy, is how can we ensure that we have the best possible quality of life depending on the treatment. So the choice and the continuation is crucial to have that quality of life elements into the decision process. But we also know that the first line of therapy is crucial, because we are getting there in the free survival is the longest when we have the first line of therapy. So again, this is so crucial that we have the good balance between the two. Psychological support, very personal. Some will need that, other won't. What we see is some countries, and I can talk about Belgium as a Belgian patient. What we see is that different hospitals, they are providing what we're calling an onco coach. And this is personal, but it is also very broad. If I may, I will just tell a few words about my personal experience. I didn't personally need really a psychological support, but my son did. He was at the time 12 years, and the onco coach from the hospital where I've been followed, they took care about that. And I think, again, this is one of the dimension which is crucial in the relation between therapist and patient, that we can provide the support, the needed support, either for the patient, either for the family around the patient. So and there the post stem cell we know that it's a real tough time. So there is probably the biggest needs if we are looking into psychological support. Last but not least, in Belgium, the University in Leuven drove a European survey around shared decision-making. And we can't disclose the results yet, but we're very close to be there. They're really almost ready to disclose the results. But we can see a trend, and the trend is that the patient is really demanding in a shared decision-making process. So it's really demanding to be part of the decision. So amongst these survey, we will see what are the barriers, what are the facilitators as well in a shared decision-making, and we'll be able, together with all stakeholders, patients, physicians, psychological support, what can we make better, and what will be the focus point that will be needed to ensure the next level of shared decision-making.
Thank you very much, Mr. Klaus, for really a nice and, I would say, very straightforward summary about the patient perspective when it comes to management of newly diagnosed multiple myeloma. Please correct me if I'm wrong. Some of the keywords I heard are about awareness about the disease, being knowledgeable of what's ongoing. At the same time, it's not about the quantity of life, but also well-being and quality of life. We should not neglect the side effects and the burden of the adverse events, because it's not only about progression-free survival. And of course, having a support team around, whether psychologists or any other interventions, are crucial in all of this, will help to have this shared decision-making with the medical team, not only the physicians, but the larger, broader medical team. So we heard this, and let me invite now Dr. Rodriguez Otero, who will give us a few hints, or what are the latest updates about managing newly diagnosed multiple myeloma. And I'm sure she will allude to the fact how to integrate this based on what we heard from the patient perspective. Paula, thank you for joining us, and the floor is yours.
So thank you very much, Mohammed. It's a true honor to be here with you and with Mr. Klaus. I really appreciate all the words and the talk. So I am going to do a briefly update on what is going on in the management of newly diagnosed multiple myeloma from the physician perspective. So it's a lot about numbers, PFS, and so on, but I am sure that we will get in a common place. So when we are speaking, and Mr. Klaus alluded to this, so when we are speaking about frontline therapy in multiple myeloma, truly the goal is to really get into the deepest response possible. And this today is what we call a minimal residual disease negativity. And this has been shown clearly in a lot of studies and in this expanded meta-analysis, that patients that achieve this deep response, so MRD negativity, both patients that are transplant eligible and also patients that are transplant ineligible, are the ones that are having a longer progression-free survival. And this is key for the lifespan of a patient with a multiple myeloma. And to do so, to really get into the deepest response possible, we need to try to select the best therapy for that particular patient that we are seeing in the consultation today. And we are still in Europe doing this separation between transplant eligible patients, patients that are candidates for high dose therapy and autologous stem cell support, and patients that are not candidates for autologous stem cell transplantation, and maybe we can discuss later in the discussion session. So for patients that are candidates for transplant, so in general, these are patients that are fit, below the age of 70, with no or very limited comorbidities. We are doing this schema, so we are starting with an induction therapy that is aiming to achieve a response in the disease, followed by intensification with autologous stem cell transplantation, followed by consolidation, and definitely lenalidomide maintenance. So the greatest advantage in the recent years has been done in the induction part, and we have come from triplets, and the oldest, I would say, standard of care that we use until very recently was the combination of bortezomib plus thalidomide and dexamethasone, VTD, and then we switched thalidomide to lenalidomide, which is the same another immunomodulatory drug, but that doesn't have peripheral neuropathy as an adverse event, and with VRD, and this is data from the Spanish myeloma working group, we can get with VRD induction followed by transplant and VRD consolidation, we can get in transplant-eligible patient a median progression-free survival that is close to 81 months, which is a very decent and long progression-free survival. But we can definitely do better, and we have moved from triplets to quadruplets. So if we build on VTD, we can add daratumumab, the anti-CD38 monoclonal antibody, to the combination of VTD, and we have data from the phase 3 randomized Cassiopeia trial that compare VTD induction followed by transplant, followed by VTD consolidation, to daratumumab VTD induction, transplant, and daratumumab VTD consolidation. This was the first randomization from the Cassiopeia study that enrolled newly diagnosed transplant-eligible patients. So in this update that has been presented very recently at the European Congress with more than 6 years of median follow-up, we do see a clear difference in progression-free survival with a median of 84 months for patients that receive DVTD versus patients that receive BTD, with also differences, which is very important in overall survival. In the Cassiopeia study, we had a second randomization for the maintenance part, and in the maintenance treatment, patients were randomized either to receive daratumumab alone or observation. I remind you that this trial was designed long ago when there was not approval for lenalidomide maintenance. And as you can see here in this slide, again, with the longer follow-up, we do see a clear benefit in terms of progression-free survival for patients that were randomized to daratumumab versus patients that were randomized to observation. In this daratumumab containing arm, there were patients that received daratumumab-based induction and consolidation, which is the blue line here, but also patients started with a triplet that then were treated with daratumumab in the maintenance phase. And very recently, there has been also the presentation of the Perseus trial that builds on VRD, so bortezomib in combination with len and dex, and this is again a randomized phase 3 that compare VRD induction followed by transplant, followed by VRD consolidation and lenalidomide maintenance versus daratumumab, again an anti-CD38 monoclonal antibody in combination with VRD induction, transplant, DVRD consolidation, and daratumumab plus lenalidomide maintenance for at least 2 years, with the possibility of stopping daratumumab in patients that achieve 1 year of sustained minimal residual disease negativity. So as you can see here clearly in the slide, daratumumab plus VRD was found superior to VRD alone, both in terms of complete response rate, 88% for DVRD versus 70% for VRD, and that translated into a superior progression-free survival that has not yet been reached for any of the two arms, and the probability to be without disease progression at 48 months was 84% for DVRD versus 68% for VRD alone. What we see clearly is this deepening of the responses across the different phases of treatment, which is also key in myeloma. So the treatment is long, and the idea behind this length of treatment is to really get into these very, very deep remissions. And you see clearly how the rate of complete response or better is increasing throughout treatment in the two arms, but more significantly in the arm containing daratumumab. And also we do see a clear increase in the rates of minimal residual disease negativity, both at 10 to the minus 5, which is the whole bar, and to 10 to the minus 6, which is in dark red here and in dark gray in the VRD arm. And you see that rates of MRD negativity at 10 to the minus 6 were 64% at 36 months for the DVRD arm and 31 for the VRD alone. So we also have data from this real-world analysis coming from the Emory University, and we do see the same. So in the real world, we also see superiority of the quadruplet therapy, in this case DVRD over VRD, in terms of PFS and overall survival. In the transplant not eligible patients, there has also been quite a revolution very recently, and we have moved from daratumumab in combination with lenalidomide and dexamethasone, the Maya study. So this was a phase 3 randomized study that compared dara lendex versus lenalidomide dexamethasone, and that clearly showed that the median progression-free survival for patients treated with the triplet was superior, 62 months, and also there was difference in overall survival with a median of 90 months for patients treated with DRD. The question is, can we improve in these very, very strong results? And the answer is yes, and the improvement is going from the triplets to the quadruplets, adding bortezomib also in the transplant not eligible patients. And we had two very recent presentations of two phase 3 randomized studies. The first one is the IMROV trial that compare isatuximab plus VRD versus VRD alone in transplant not eligible patients up to the age of 80 years. So this is the study design, and the trial met its primary endpoint, showing superior progression-free survival for patients treated with the quadruplet ISA-VRD versus VRD alone. And the median PFS was not reached for the ISA-VRD arm, and it was 54 months for the triplet arm with bortezomib, lenalidomide, and dexamethasone. There was also superior rates of MRD negativity in patients receiving the anti-CD38 based therapy. And we have another phase 3 randomized study that is called the BENEFIT trial, that is led by the IFM group. And this study compared isatuximab plus VRD versus isatuximab lendex. And we can consider isatuximab lendex as close to the standard that we are using now, daratumumab lendex. And again, this is the study design. The primary endpoint of the study was MRD negative rates. And again, the trial met its primary endpoint, showing a clear superiority in the rates of MRD negativity, both at 12 and 18 months, both at 10 to the minus 5 and 10 to the minus 6, in favor of the use of the quadruplet therapy. But for sure, all transplant not eligible patients are different, and definitely the treatment decision should be frailty adapted. It's not the same to treat a very fit patient or a patient that is frail or vulnerable, and this is definitely need to be taken into consideration when deciding about the different options. So to conclude, so we know that long-term disease outcomes are associated with the achievement of MRD negativity. In fit patients, probably quadruplets are the standard of care. If the patient is transplant eligible, probably today still transplant is recommended. In intermediate or frail patients, then the decision should be a balance between the efficacy and the safety, and probably frail patients are better suited for triplets, and intermediate, maybe we can consider quadruplets, and then eventually de-escalate in the event of toxicity, but still a lot of data forthcoming.
Thank you very much, Paula, for a beautiful summary. Actually, you managed just in a few minutes to summarize some of the latest and amazing, actually, results that were achieved when it comes to newly diagnosed multiple myeloma, Perseus trial in the transplant setting, and now one probably would speculate that the median PFS is going to be more than 10 years. And then, of course, the IMROS data with the quadruplet in fit patient, and one would call them unprecedented. Maybe I'll invite again Paula and Vincent and get your thoughts on this case I've seen recently. Let's call him John, a 67-year-old gentleman. You can see he's not overweight, classical history of hypertension, diabetes. He lives alone, but he's very close to his two daughters who live 2 streets away. I've seen him in September 2023. He had some back pain. And to make a long story short, you can see the details, but this is an IgG lambda multiple myeloma, and it's a bony disease. So here I'd ask our panelists, which therapy would you choose for John? Is it a triplet or is it a quadruplet? And when I say triplet, for instance, you may wish to think about the classical historical VRD, bortezomib, lenalidomide, dexamethasone. We heard about the quadruplet from Perseus, Dara VRD, daratumumab VRD, or at IMROS, we had ISA VRD, isatuximab VRD. So, Vincent, what do you think?
Yeah, that's a very good question. Again, it's very complex for a patient to say probably triplet or quadruplet will be the best. I think I'm not the best to point out the best case, but I think it's important again to share the results of what we saw the last couple of minutes, the results of quadruplets versus triplets. So it's important to inform the patient about the recent quadruplets and how beneficial it is for the patients. But on the other hand, we need to really understand from a patient perspective what would be the adverse events, for instance, or what would be the risk related to a quadruplet. Adding DARA, for instance, what does it mean for a patient? What does it mean in terms of quality of life? What does it mean in terms of risk regarding the diabetes or the hypertension? So again, it's from our perspective, it's really a matter of being informed. So and based on the information that we have, we can decide together with you as therapists what probably best fit for John. But I think it's a matter of communication and information.
Thank you, Vincent. Very well taken. So, Paula, from your perspective as a physician and based on the evidence-based data you shared with us, how would you handle this patient? Because as you may guess, I have chosen slightly borderline patient, 67. Yeah. You may think he's already an old gentleman, or you may think he is still relatively young. So what do you think, Paula, here?
Yeah, I think that the choice of the patient is not innocent, I would say, and I am really curious about what triplet patient, I mean, the people that is watching the webinar is thinking about, because maybe some of the triplets is daratumumab in combination with lendex, more of a Maya based approach, because they consider these patients being not transplant candidate over the age of 65, but others that will say quadruplets are eventually thinking of doing IMROV or perfusion, dara VRD, or isatuximab VRD. So for this patient, taking into consideration the age, 67, the comorbidities that are not that rare, I mean, the patient has hypertension, diabetes, but are well controlled, no significant organ damage, I will probably go for a quadruplet, so either daratumumab VRD or isatuximab VRD, because I still consider this patient fit enough to go for a quadruplet. Then the question, because of the age, 67, is whether, for me, this is a patient that is going to be candidate for transplant, in which I would say, okay, induction with a quadruplet followed by transplant, and then a consolidation and maintenance. I would probably say, yes, for me, 67 is still a candidate for transplant in theory, so we need to evaluate comorbidities and so on, and of course, patient perspective and patient preference, but probably in my mind, this is a patient in which I will go for quadruplet, aiming for this deep response to really get the longest progression-free survival possible.
Thank you, Paula. The question we have is how to balance when we decide to treat newly diagnosed multiple myeloma, biological versus chronological age. And I think you already alluded to the comorbidities. For instance, do you use some scoring, some questionnaires in order, or you just rely on clinical judgment to make the distinction between chronological age and biological age?
Yeah, so I think that this is one of our rooms for improvement, so I am not using formal frailty scales, so formal frailty evaluation, and I typically rely on comorbidities, polypharmacy, ECOG performance status to get an idea of frailty status of the patient. That probably is not ideal, maybe it can be improved, but at least this is what we are doing. At the beginning, if we consider, or if we, after doing all this, Charlson comorbidity, ECOG, polypharmacy, and so on, if we believe the patient is fit, we would start with a quadruplet, and then if we consider the patient may be candidate for transplant, this patient also get a second evaluation from our transplant team, again with their scales and their and they will also give us another impression about whether the patient is